Good afternoon and welcome everyone. It's good to see you all. Today, I believe that, well, I'm not sure who's leading it, our presentation. Is it Commissioner Lyman Torres?
Yes.
Seems like I just saw you and Aaliyah not too long ago in the same format. But okay, we never see you enough, so please go ahead.
Okay, thank you so much, President Scott. I did agree in that format to come back with an update. So we're here today, and I'd like to introduce the members of the team that have joined me today. I have Sarah Fletcher, who is our new Deputy Commissioner, and Aaliyah Hinton-Williams, who is our Manager of Crisis Services. And of course, Chief Sullivan, Harriet Sullivan, has joined us as well and can certainly chime in. But I wanted to fulfill the obligation to come back and to provide an update on crisis intervention services. I do have some slides to share with you and to go through and answer some questions, talk about kind of what's been happening over the course of the 6 months as we come to the end of the pilot phase and answer any questions that you may have in that regard. So I'll just start by, reiterating, especially for those watching, the purpose of the Office of Crisis Intervention Services, just because I think that there has been some kind of straying in the language and thought process because of the way the pilot has gone. But the purpose of the office is to have a civilian-led, community-based response to support people, victims and families, people in crisis. It is to do crisis services, not to deliver mental health services. The differentiation there is that crisis services is to address an immediate need and to make a connection for ongoing support services that is delivered throughout the healthcare system that exists. So we wanted to take and create an alternative to law enforcement so that law enforcement could focus on responding to other types of situations by using highly trained professionals for these types of responses. Just a kind of refresher, we started the office and launched the office with 4 teams, looking at the existing teams that have been transitioning from RPD, which was FACET and victims assistance, and what they were doing and how we could really work to bridge that work together in this new office model and work together. So as we're launching this upcoming fiscal year, the team is going to be, community support team, which is going to be focused on providing those same assistances to victims, but also making sure that the referral base for this is RPD continuing, but not just RPD, also the PIC team, also Pathways to Peace and internal referrals that we really need to continue to be able to have access for the community to get support. And again, this support is short-term, it's immediate response, and it's a connectivity to services that are ongoing in the community. So that's just an overview of some of the transition in the services and who's doing what on the team. The PIC team itself, as we launched on January 21st, is a first responder team, again, designed to de-escalate and do an assessment, make a connection to community resources if that's appropriate, and then also, if it's appropriate, make a referral to an immediate emergency services or medical services if that's deemed appropriate. While PIC did start out with mental health calls, it is intended and designed, these programs across the country that have been in pilot, to be a law enforcement alternative that also looks at family trouble, wellness checks, and some nuisance calls, and will be talking and working with the chief and the team to identify those opportunities as we go beyond the pilot phase. But I know we started with mental health, and that's because of the situations and the catalyst in our own community, but it is deemed to be broader than that, and we will be going beyond that past the pilot phase. The team itself, just to give an update on the team itself, as a reminder, it is a team of emergency response social workers. They're behavioral health professionals. They work in teams of 2, and we are on duty 24/7. And we have on shifts where we have a lot of activity, and we've been able to track that over time. We have more than one team, so there's 2 teams of 2. To be able to meet the responses, which I'll give an update on that as well. Of the 30 positions that we have had, most of those are part-time positions. There are 5 full-time positions, and the rest are part-time positions. We have been able to fill those positions successfully. Aaliyah and her team have worked really hard to do that. But we also have a lot of clinicians that are interested in being a part of the solution. So we have been able to recruit and retain staff that are familiar with the community because they live in it, and they are representative of the community as well. We did begin our responses again with mental health. We started alone, just responding to calls alone in January. And by the time the new computer aided dispatch or CAD system was ready to roll out with 911, we were able to go into a co-response, which we know the community was interested in us doing alongside RPD, but really being dispatched with them and not requested by them, which was the difference. And so we've been going out at 911 dispatch as every type of mental health call comes in, but there are 3 types of those calls that are designed for the PIC team to go alone. We have been able to post our data. We have a dashboard up on the city's website, cityofrochester.gov/crisis intervention, where the public can find this updated on a monthly basis. And we're able to track the amount of calls that the PIC team is responding to, and also how many of those that they're going alone. Because one of the challenges that we're seeing as we round out the pilot phase is, since we've done the co-response, the number of PIC alone calls has gone down. And we had to do some deep dive into what might be causing that, because it is designed to be a law enforcement alternative response, and we want to make sure that we're doing that to fidelity. But what I can say is that, we're definitely averaging, around 20 calls a day, sometimes more, but that's again an average, or between 120 and 160 calls a week. So it is a very busy response by the PIC team. They are going out a lot and responding to the community. Again, we aren't necessarily at baseline with the number of PIC alone calls that were expected. And so we wanted to deep dive into that. And we've been working with the 911 team on solutions. One of those solutions has been to lift the call filters that may have been contributing to that happened as a part of the CAD rollover. We've been able to identify that and lift those. And also we're working on exploring the questions, because we know there's been a lot of conversation about what it would be like to have a clinician at 911, or what impact would that have on being able to really take the right kind of calls and get them to the right resources, because we are struggling a little bit with definitions. For example, the definition of violent. If I call and I'm the person identifying that you might be violent, I may have a different description of what that is. You may just be angry or agitated and not necessarily violent. So we want to make sure that we're looking at all of those, because they trigger a response from law enforcement that don't always need law enforcement. We get to scenes and find that people may be, not violent at all and never really were. And so that could have been a call that PIC could have done in lieu of RPD. I just to round out next steps, and then I'll open it up for questions. We have to evaluate our pilot as we get to the end of June and create a summary report across the country. Other cities, Denver, Chicago, Portland, who have done similar pilots have published their findings in their reports. We have found those helpful to us as we've been going through this, and the community is interested in making sure we do that. We have received funding, or will be receiving funded peers by FLIPS, which is the Finger Lakes Provider Performance System. They will be funding 4 full-time people with lived experience to integrate into the PIC team for a year. And they will evaluate the impact of having people with lived experience supporting the PIC team with connecting people to resources that hopefully they can stick with, and use those peer navigators to help guide themselves into long-term services. Again, as I talked about the community support counselors, it's important that we have a mechanism to continue to get referrals from RPD, the PIC team. The Pathways to Peace program has long needed a place to provide, to get referrals and supports for people. 211 internal, and also the community needs to be able to reach out and say, there's a person that needs some connection to service. Again, we're just making those connections and following up to make sure those connections were successful. We will also, as I said, expand to other call types. And as we've talked about, we do need to identify long-term funding and sustainable structures for the programs and services. If crisis services is not something that we will want to engage in long-term, how are we going to transition that, if we do, into the community? And how can these things be funded? We are receiving technical assistance paid for by Bloomberg to help us with identifying these kinds of resources. We looked at other models. For example, the state of Colorado uses some cannabis tax money, as well as some Medicaid dollars to support their crisis services. So it's not funded at the local municipal level. And there are some other models as well. So we want to continue to look at how are other states funding their crisis services in a way that doesn't put all of the pressure, the funding pressure, at the local municipal level. And how can those learnings be brought to Rochester for us to think about these programs differently? And I'm going to stop sharing my screen and just before I open it up for questions, I just want to give Aaliyah an opportunity to share a story from the field, just to kind of give a little bit of insight to those watching and members of council as to what we are experiencing, the team is experiencing. Aaliyah?
Okay, and this call came directly from our lead team members, Dre Johnson and Renee Breen, and they talked about a co-response call that they had with RPD as well as EMS. And this was for a woman who was homeless, and the call was on Alexander Street. Unfortunately, her child had been taken from her at some point due to her substance use issues as well as her mental health issues. And once PIC arrived on the scene, they were informed that they were no longer needed because a decision had been made for this young lady to be taken to the hospital. And at that point, PIC decided that they still wanted to stay and try to assist on the call. They did an assessment with her and found out that she was not a threat to anyone. She was not suicidal. She was not homicidal, but she was feeling very depressed about having lost her child and some of the life challenges that she had been facing. They were allowed to speak with the person, and she gave them some background information on herself and her child, and decided that that morning, in fact, she wanted to make a change. And so that was how she ended up outside and seeking some type of assistance. Um, the PIC team was able to further interview her and assess her, and she told them that she did want to go to a facility immediately for some treatment, and the PIC team was able to arrange for that to happen. And they were able to connect with the treatment facility as well as be able to make arrangements for transportation and get her to a rehabilitation facility where she was able to obviously begin that process. She was very thankful and grateful to the team. And that's just a short and one example of the work that they've been able to do in real time and immediately, so that people are given alternatives and aren't being forced into kind of those traditional responses, which, as we know, are to go to the emergency room. And everyone doesn't need to go to the emergency room. And we have many resources in our community and outside of our community that are able to address these types of needs. And so she was very excited about having that presented to her. And again, we were just grateful to be able to provide that type of assistance and to be able to do that consistently and really on a daily basis.
Aaliyah, how did the call come in?
The call came in through 911 as a call response with the police department.
Thank you. Councilmember Pio, you have a question?
Yes, thank you. Quick question. When it comes to the point where the PIC team shows up and it gets to the elevated part of where police officers have to get involved and arrest the person or take them away, are PIC team members able to be deposed?
When necessary, yes. And I guess, yeah, that's the answer to your question. But I just want to say that, you know, our goal isn't to call for folks to be mental hygiene transported if they don't need it. Our goal is to get people to the right level of service. And if it's determined that an involuntary, transport to the hospital is the right level of service, then RPD and AMR handle that. And the PIC team is there to assist and support the person with follow-up. But we also do work with RPD to make sure that we're available to answer questions in the follow-up from every call that we can.
So they are able to.
If I could weigh in on that too, when we're talking about a behavioral health issue or a mental hygiene arrest, that's one thing. But sometimes, I agree with Dr. Lyman that you should be a last resort. But if you're on scene and some other issues come up, and through no one's fault, there may be a criminal matter involved, then yeah, that definitely, because then they would be considered a witness. So I just wanted to differentiate the two. So
Thank you. And I think you alluded to it before. Are we talking about getting actual doctors involved so that they can be able to go out with the PIC team as well? Or I thought I heard something on that one.
No, we aren't looking to have doctors go out with the PIC team. What we are looking to do is to have peers that are people with lived experience that can support the PIC team with connecting with individuals who, also are going through either a mental health or substance use crisis.
Now, what happens though when it's just a matter of they didn't take their meds? Is there a way to have medication there and say we probably don't have access to their medical history? Okay.
No, that wouldn't be particularly safe. At that point, they would need to go to the hospital and to be seen by a clinical pharmacist and the right medical professionals for that.
Thank you very much.
Yep.
That Councilmember Peel, that question sort of brought immediately to mind the incident. I'm not sure what city it was in, but the first responders, and I guess they were police, actually administered some type of drug to this young man who was
Probably Narcan, maybe? No?
No, it wasn't Narcan. It was, I can't remember what it was, but they actually killed him. He was,
Ketamine.
yes, that's what it was. They killed him. They thought they were calming him down, although he didn't even really need to be calmed down. So that opened such a broad array of potentially negative outcomes when we get too far into that. Are there other questions?
President Scott, I just have a comment.
And I'm seeing only a phone number here.
Yeah, this is Mary.
Okay.
So does the hearing. Yep, I'm on the phone. I just wanted to say that, to add to the point that the hospital isn't always the best option. I had just a constituent calling me from the hospital. We had been connected on another issue, and he started making suicidal remarks. And so I felt like I had to, relay that to the folks at the hospital. Ended up with him being mental health arrested and in the psych ward for 3 days. And, I stayed connected with him that whole time, and I was horrified what it's like for someone to go into that environment. And it's like a third world country. He stayed in a waiting room for 3 days while they were involuntarily injecting him with Adderall. And I would just like to say that, if we can avoid that outcome, I think it's better for the person, and it's certainly better for the system to not have someone be in there that doesn't need to be.
Councilmember Gruber?
Yeah, thank you very much. And Commissioner Lyman Torres, I got zoomed off of the Zoom for a few minutes. So if you wouldn't mind sending the presentation around to staff, just so I can see the slides, I'd appreciate that. Just a quick question about the funding from FLIPS. To Councilmember Lupien's point, that's kind of exactly what FLIPS is trying to do, right? Is try to keep people out of the emergency room if that's not the place for them to be. How is that whole process working, and how is FLIPS trying to connect into a better, how is FLIPS trying to guarantee better health outcomes for these individuals?
Well, I reached out to FLIPS, because of this one, this particular goal that we have, the metric we set up about decreasing ED utilization. And, so this is how that came about. It wasn't necessarily on their radar as a area. But since then, they have agreed to fund not only peer integration for our work, but in other work as well. And how that will work is that they'll do an RFP directly and then place those peers with us in the PIC team for a year. And then they will also do the evaluation to be able to look at that link between ED utilization and the work that we're doing with this crisis mobilization in the community. Can we have an impact by, again, deferring people to community-based and other types of resources that will actually help them. The emergency room is not really established for that. It secures people's vitals and then releases them. And we're constantly seeing the same people, needing that service again and again because they're not getting connected to the right service. So FLIPS is going to also help with that portion of the evaluation.
That's huge. I really commend you. I've worked with FLIPS a lot in my day job, and it's a very difficult system to navigate. But I really commend you on connecting the dots there. That's huge, and I would really hope that part of the goal for FLIPS, from my understanding, is for them to be able to connect into insurance companies and hospital and medical systems to be able to pay for some of these things long term, which I do think ultimately, I mean, President Scott talked about this the other night during the budget hearings around, how much can our tax base afford to be able to continue to take on additional services. But when we begin to connect with insurance companies and healthcare systems, giant ones that have budgets that outstrip the city's entire budget, that may be a pathway forward for some of this work. So kudos to you on that. Just last question, and I'm sorry if you already answered it in your slides, but what is the connection at this point to Monroe County? How are we working with the county? Did you answer that already?
I didn't. I will. I do want to just say too, on that funding piece, we are exploring all of that. There are a lot of moving parts right now at both the federal and state levels around funding for crisis services, because this is becoming something that communities want and need. So I do think there's going to be movement around whether or not, some states have been using Medicaid money. Some states have used cannabis tax money. Some have used other special taxes. So there's other ways that states have been doing this. We will be exploring that, and we will be sharing that information with our state delegation as well, so that they're aware of what's going on. Because right now, until Buffalo launches something, we're the only ones doing this right now. So it's just like this with this frontline support. So it's important that we learn from other states and share that with our state. But to the county point, we are working very closely with the FIT team. We have been training together, meeting together, coordinating our services, because we know that even together, we don't necessarily have all the resources necessary. So we're responding first with RPD. If PIC is unavailable, FIT is available, and we're staying in close contact with them, as well as the Office of Mental Health, the County Office of Mental Health. I meet with the director regularly and the commissioner of DHS regularly, and we are staying connected on this. DHS in particular at the county is grateful for the opportunity for more front door access to DHS services, and the PIC team and the community support team can do that. And so we've got liaisons, and we can do direct connect for people with DHS and get people connected very quickly to the services that they need, which is very important, especially to victims of crimes and violence, that we're able to do that. So we have been working very closely with the county, and we'll continue to do that.
Commissioner Lyman Torres, I think you just alluded to, or maybe even answered a question or concern that I have about, we're talking about this in terms of crisis services. And I think it's much more than that, that people may be made aware of these individuals who need help as a result of a crisis, but that crisis is reflective what in many cases an ongoing situation or condition that the person may be suffering with. And there is, unless something has happened recently, there is a gap in the availability and provision of services on an ongoing basis for folk who need mental health support. I'm not advocating for the return of the psych center, not at all. But I believe there is a gap that's being, if not ignored, just sort of worked around and being dealt with through the crisis services. Now, you talked about access to the front door. Maybe that's what you're talking about. Maybe there's a front door that goes to some services that people get once they get identified via the crisis avenue.
No, you're absolutely right. We have identified a gap. So we've seen this in our work as we've launched this pilot. We've seen it up close and personal. And what we can see is that there are some people who could be connected to existing services. There's definitely a gap there with getting people to the services that do exist. But there's also a huge gap with community-based support services that can help people with mental health and substance use disorders stay stable between their providers. There's other populations that get that kind of service community-based service, community habilitation services, where people will go a couple of times a week and help people with grocery shopping and help people cope and get through the things that are challenging between their visits to providers. That is a huge gap. Nobody's doing it, and they're not doing it because it's not funded for this population. It's not funded for people with mental health and substance use disorder at the state level, and that's a real problem.
Right, right. Councilmember Melendez?
Yes, thanks, President Scott. So first, Commissioner, I just want to say that, this has been a lot of work in a short period of time. So I commend you for all the work you put into this. I have two quick questions. One is, in terms of the county, I know that, the county has a health department, the city does not. So in many ways, this is a new foray for the city to get into this. Long-term, do you envision that there might be some talk about, who's the right entity to host this? Or is this something you think that the city, I know we're committed to it right now, but you think this is something that's in the purview of the city to maintain?
Well, I think we have to continue to monitor how we're using it. So if we're using it as a law enforcement alternative, we definitely, in a first responder model, we definitely need to that's something that is not always municipal at the end of the line, but it is at the beginning. And so, for example, the Cahoots model that we looked at first, that's an outsourced model. The Whitebird Clinic is not a part of, the city of Eugene. So, but they have a contract with the city of Eugene to provide that service. So we are looking at those models as a part of the technical assistance that we're getting. We're looking at how people are doing that long term. I will say that the city was doing and was providing victim support services, and Facet has been around for a very long time, providing short-term kind of counseling and connection. So at some level, there has to be some level of crisis coordination and service that just happens because the municipality interacts with people in crisis, especially the police department. So I think the longer, answer there is that I think we have to explore all the models for delivering certain aspects of the service, but at some point there has to be some connectivity to law enforcement at all points.
Sure. Thank you for that. And the second question is, the county has the impact team that is just getting off the ground, focused on substance abuse and trying to help folks get into recovery. And I'm just wondering if there's been, obviously not everyone, not everyone has a substance abuse problem just because they have a mental health problem, but has there been some coordination around that, and how do you see that working together?
Yeah, absolutely. We do coordinate. We work directly with them. And, a lot of times we'll talk about going out and, working with people together, identifying people who have been in crisis, who may be ready and at a place for, services. As you know, we have to meet people where they are. And sometimes we see people a number of times before they're ready for a connection. So we have been working together to identify people in particular as the team has been navigating the city.
Okay, thank you.
Are there any additional questions? Comments? Concerns? If not, I'd like to thank you, Commissioner Lyman Torres and Ms. Hinton Williams and Sarah, and of course, Chief Harriet Sullivan. Thank you so much for coming to inform and update us. We are adjourned. Have a good